So that I love the fact that you just want to keep talking. This is like this is why I want you here. So if anybody has trouble hearing during the course of, when we're speaking, please feel free to move up. If you want to do that now, go ahead and do that. I wanted to just tell those of you that haven't been here before, just a couple seconds about the Wise and Wonderful Women. I, during the course of my job as a real estate broker, have come across so many awesome human beings, but especially women. And in my crazy, busy life, I don't get a chance to really kind of connect with them or connect them together. And so when I saw this room, when I moved to this crazy, Oz down here at Hudson Yards, when I walked in here, I just felt like this was the place that I was going to be able to bring people together. So I want to grow the group. I want us to be informed and inspired by each other and support each other. So please, just to be able to keep in kind of contact, join the Wise and Wonderful Women Facebook page, just because you'll be able to learn about events, suggest speakers, and just be able to keep in touch. So the other, and I wanted, Inez works with me, and I want to thank her for getting all these bios together. Huge job. But just reading through them, I love the night before these events and reading through what awesome women that are in this room. So anyway, I want to, speaking about awesome women, we got ringers off. We have, you dropped it.
Oh, thank you.
So I want to, so let me, everybody's got their ringer off, right? Okay, so Wednesday actually introduced me to Chris. Chris is actually my new gynecologist. And what I've been wanting is somebody that actually listens to what's going on with me and doesn't just kind of hand me a prescription and kind of comes up with what could be going on with your body and actually spends time asking the questions. And so I just saw her for the first time and felt so listened to and cared for. And anyway, that is besides just, and then when we asked for your headshot and she had Trust Women on there, I was like, you are my girl. So anyway, that is my introduction, but here is her official introduction. So Dr. Creatura is a gynecologist and sexual medicine specialist with the expertise in menopause and adolescence. She's a clinical assistant professor at Weill Cornell Medical College and sees patients in her private practice in New York City, in Manhattan. She's certified by the International Society for Women's Sexual Health, the North American Menopause Society, and she is a menopause practitioner and serves on the board of directors at Planned Parenthood of New York City. There are, there's also information about Planned Parenthood in the back. There's some brochures and also some cards, so please feel free to grab those. Chris is also a graduate of the Leadership Training Academy of Physicians for Reproductive Health and an active member of this organization here in New York City. She is a sexuality educator, reproductive rights advocate, and a propaganda. Thank you, propaganda, sorry. And I can't speak English. So anyway, welcome to Chris. Delivered many babies of the women many of the women that are here, because many were coming anyway, and they're like, she just delivered my babies anyway. So Dr. Wednesday Martin, she is a feminist and cultural critic and a #1 New York Times best-selling author who focuses on gender, motherhood, parenting, and female sexuality. Her book Untrue is about female infidelity and the bias in science of female sexuality. Wednesday is a columnist. Her work has been featured in a variety of prestigious publications such as the New York Times, the Atlantic, and many others. Her 7 books have been translated into 20 languages. Obviously an underachiever. She has appeared on various radio and TV programs including NPR, The Today Show, GMA. Wednesday co-hosts the #1 rated iTunes relationship podcast, True Sex and Wild Love, about sex and open relationships. And she is consulting producer on the Paramount Television scripted series Infidelity. She's a mother of 2, and she lives on the Upper West Side in Sag Harbor. She serves on the board of directors of the Civil Rights Museum of Harlem and is an active supporter of the Children's Museum of the East End's Head Start and the Ciencia programs for Spanish-speaking children living in poverty on Long Island. She earned her doctorate at Yale, where she taught cultural studies. Welcome, Dr. Wendy. There's so much to talk about on all of these, this entire topic, but I didn't know whether you wanted to start with how you started with Untrue. I mean, there's also the button, so you take it away, girl.
Right. Okay. First, I want to thank you for bringing us together, all of us in this room. I want to thank you. When I thought that I would never be able to find my libido again, when I was wrecked on the desert island of Menopause, and I thought I would never have a coherent thought again, let alone another sexual desire. This woman saved my sanity and my libido. Wow. And lastly, I want to thank all of you for being here. We live in a culture that does not value female sexual desire or female sexual pleasure. You are discouraged from engaging with your desires, and I want to honor the fact that you're in this room and that you're curious about female sexuality and that you feel entitled to learn about it and talk about it. I honor that you're here, and I thank you so much. So Anne told you a little bit about me. The bottom line is that for my whole career, I've been blending social science and storytelling to help women understand themselves in new ways. And I like to say that I was born when I was 50 years old because that's when I discovered something. I'm going to show it to you. We're going to play a game. If you know what this is, raise your hand. Right? But don't say what it is. How many of you in this room know what this is? Okay, now. Okay. Now, if you don't know what this is, I want you to just guess. Only if you don't know what it is. If you have no idea what this is, just look at it and guess. Go ahead, who wants to guess?
Drumstick from Thanksgiving.
Very good guess. Wrong, but a very good guess. Yes?
Clitoris.
Okay, good. You wrecked my game. Good job. Yes, you were right. So don't feel bad. I gave a talk to a group of women scientists in North Carolina recently. 120 women doctors, actually, and many of them, sorry?
I don't know if they all heard.
It's the clitoris. This is a model of the human female clitoris. Chris is going to whip out her pelvis. So that you can all look at it.
Not my pelvis.
So I'm going to pass this around, all right? Whenever you have it in your hand, you can think, ooh, now I have 2. So I asked a group of 100 perspective. Yeah, there's a great perspective. I asked a group of 120 female doctors in North Carolina if they knew what that was. And yeah, this is where it goes. So the doctors told me they thought it was a chicken foot. So don't feel bad. So this is the glans of the clitoris, the part that you've been taught about if you were lucky to learn, the part that you can see with your naked eye. It's called the glans. It's very sensitive. Down here we have the crura. That's a lot of erectile tissue underneath your labia. It gets hard.
It's inside.
It's inside. This is the internal clitoris. Okay? In addition to the crura. Sorry, these are the labial, these are the vestibular bulbs. I misspoke. Under your labia, they're the vestibular bulbs, they're erectile tissue. And then winging back are the crura, and they sort of wing back toward your anus. Okay, so all of this that you're looking at is much, much vaster and bigger than you were ever taught. Your clitoris is dozens and dozens of times bigger than you were taught. I like to say that the part of the clitoris that you know, this little tiny part right here is just the ticket to the roller coaster ride. Some people say it's the tip of the iceberg, and I say, no, it's not. It's the mouth of the smoldering volcano. This is quite enormous. It's 9 centimeters to 12 centimeters. It's all erectile tissue. When you wake up in the morning, you have an erection. When you are sexually excited or even just attracted to someone, you get a hard-on. Something to think about, something to try to tune into. I'm going to pass this one around as well. Okay, I told you I was born when I was 50 years old. That was the day that Latham Thomas, who's sort of the doula to Black Hollywood and an amazing pleasure educator, said to me, we have all these maps of the reproductive system. We know what the reproductive system looks like. Where are the maps of the female pleasure system? Where are the maps of the female erectile network? Where are the maps of the internal clitoris? And I said, what the hell are you even talking about? Googled female erectile network. This popped up and it blew my mind. I was a 50-year-old feminist. I had studied sexuality and feminism for years. I thought that I knew my body. I had been studying sex in specific for many years. And I realized if what I had been taught about my clitoris was untrue, what else that I had learned about female sexuality was untrue. I like to say we put a man on the moon, we sent a rover to Mars, and we mapped the whole entire human genome before we figured out the most basic fact about female sexual anatomy, because priorities. So I set about to write a book about what else about female sexuality is untrue, because I wondered, if I don't even know my own clitoris, what else don't I know about my sexuality? And the answer was a lot. So that's why I wrote Untrue, because I learned that my clitoris had nothing to do with what I thought it was.
Well, the crazy thing was in the button, you were talking about how the medical books and it didn't even exist in the books. It was just not even there.
So Chris can speak to this, that a female urologist named Helen O'Connell was doing urological surgeries, and she was told, do not damage the nerve supply to the penis, that would be a catastrophe. And she said, oh my God, I would never. You guys, how do I protect the nerve supply to the clitoris? And they said, what are you talking about? Because nobody even knew.
Right.
Tell the story.
Well, I became very famous at school and when I was in medical school, because there was a very renowned surgeon who came to speak to all of us when we were first-year students. And he also happened to be the father of one of the people in my class. And he was a professor at the Brigham and Women's, and he came to talk to us about the kind of colorectal surgery that he was doing. And he just sort of casually mentioned that, while he's showing us the diagram, when you move the colon over in a man, you have to be very careful not to damage the pudendal nerve. And the implication was that we would all understand that obviously you need to do that in a man and not in a woman. So of course my hand shot up immediately, and everybody in the class in the front row, who happened to all be men, was starting to look back over their shoulders like, what is she going to do now? I said, you mentioned that you have to be really careful in a man, and I was wondering, do you not have to worry about the pudendal nerve in a woman? And he looked absolutely baffled. He had no idea what I was talking about.
Right.
Absolutely, really sincerely not even conscious of what I would be talking about. And so I had to clarify for him that you could damage the pudendal nerve in a woman. And he said, well, that wouldn't actually interfere with her functioning. And I said, well, do you mean it wouldn't interfere with her reproductive functioning or her sexual functioning? And he still looked at me like he really didn't understand what I was talking about. And most of the men in my class had the same kind of a reaction. I don't know if it was just because I questioned this renowned surgeon, or if it was really the idea that, oh yeah, it's not just reproduction, right?
Well, and this is the thing that Chris and I have talked about, and we talked about a little bit too, is that what has happened over the last 30 or 40 years is that women have entered field science, primatology, medicine, and sex research. I like to say that sex researchers are a female-dominant species, because in Canada, for example, there are now more female sex researchers than male sex researchers. And what has happened is, because of these new forms of curiosity and sympathy and compassion that scientists like Chris Creatura are bringing into the field of human sexuality, we're rounding out the picture of sexuality, and we have all this new data about what female sexuality actually is. A lot of it is a 180-degree turn from what we thought it was, but the data have not been crossed over into your hands yet. So that's what I'm trying to do in my book, cross over all this data that mostly female researchers have produced about who women really are sexually. And I think it's also what activists like Chris, who are also scientists, are doing.
Well, you're very generous, because I'm not really a scientist, I'm a clinician, but I think she likes to think of me, and maybe I'd like to fantasize about myself as a
Medicine
scientist.
is a
We
science.
definitely are pro-fantasy in this room. So we'll go with whatever fantasy works. But I do feel as a clinician that it's clear to me in working with scientists and working with patients that everybody's interested in this topic, and we're all feeling as though there's a great dearth of information. So there's a great deal of things that I wish, if I were a very wealthy scientist, that I could sit around and tell my young researchers to do, because I'm filled with project ideas. But I actually don't do that research. I just see patients in the office and teach students.
And some of the most basic ideas about female sexuality that have been overturned recently, mostly by female researchers, one of the biggest ones, and that I try to get to the front and untrue, is that there are emerging really strong data and established data which show us that monogamy is a tighter shoe for women than it is for men. That it's women who grow bored of partnered sex more quickly than men do. And that was one of the things that really blew my mind when I saw some of the longitudinal studies about, yes, and we're told that men struggle so much with monogamy, but when we look at the data, what happens to male sexual desire in a long-term relationship over 9 years is it goes like this, right? It ebbs down really slowly. But female desire in a heterosexual relationship, here's what happens to it over the course of 9 years. Here I am, years 1 to 4. Boom! My finger's in the sub-basement. Okay, when guys were doing sex research, everybody was happy to say, oh, of course women have lower desire in a long-term relationship. They like sex less. But female sex researchers thought to ask these women, what would happen if you could have sex with somebody else, not your husband? And they said, oh, hell yes. And their libidos went up to the 90th floor. So to me, that's one of the most compelling bits of data that has emerged from this new sex research that women have been doing, is that we're getting to the bottom of this epidemic of female sexual boredom and of women thinking, I've gone off sex. If you are a normal human female and you are bored of sex in a long-term partnership with the world's most perfect man within years 1 to 4, you are a normal human woman being a normal human woman. And I think to cross that information over so that women stop saying, I don't like sex, I've turned into my mother, I'm a cliche.
Right.
You haven't gone off sex.
Habituated to the same
You've
stimulus.
habituated to the same stimulus. You haven't gone off sex. You've gone off sex with the same person over and over and over because you're a normal human woman. It happened to you before it happened to the guy in your life. Now what?
And sometimes I think that there are some evolutionary reasons for that there might not be a reproductive imperative to actually continue to have insertive sex with a man, that there might be some kind of reproductive imperative to actually find something that's novel, a new stimulus that's arousing.
Yeah.
So I think that it's interesting in human males that there is such a steady interest that I see when I deal with couples, that many men are very happy to stay with the same partner. But if she stops having sex with them, they'll be more likely to actually stray out of the dyadic relationship.
Do you think it has to do with feeling kind of not connected? Because I don't know, is it physically that you're saying like that you really need something different in a relationship, or is it just feeling like that maybe you're not connected to your partner,
Okay.
or you're saying he's Mr. Perfect and he is attending to your emotional needs too?
Okay, well, I think that, first of all, what Dr. Creatura said, I'm just going to call you Chris, even though I always believe in women using their honorifics, but we're friends. But I think that women evolved to crave variety and novelty and adventure. It's a good thing. You're shutting down because you're not getting enough of it, and I get into that in my book, but I believe what Chris says about the evolutionary imperative. I also believe that exactly the opposite of what we think is the case is the case. Marta Miana, a sex researcher at the University of Nevada, Las Vegas. That must be a hell of a place to be a sex researcher. Asked a group of women who were reporting distress. She said, I'm going to get into it. There have been all these longitudinal studies that show women get bored, women don't want to have sex after a few years, women are struggling with monogamy. Okay, she said, let me actually talk to these women. Let me get in the trenches and have long conversations with them. She talked to 20 women who were extremely distressed that they didn't desire their husbands or long-term male partners anymore. And here's what she found out was going on. Was it that these women didn't feel emotionally connected to their partners? No. It was that they felt way too connected to their partners. And what Marta Miana found is that if a man, just going to give you an example, leaves his dental floss on the counter in the bathroom, that's it. It's over. There's no sex tonight. If a woman and a man are having baby talk like a couple, she's like, I'm out.
Right.
If a woman and a man are together and then they put a ring on it and move in together, guess whose libido that kills? Not the man. So what Marta Miana found when she broke it all down, when she talked to these women for hours and hours and hours, is that there are 3 things that dampen the female libido that do not dampen the male libido, and they're going to surprise you. Domesticity, over-familiarity, and I'm in menopause, what's the third one? Oh, the institutionalization of the relationship. Those are the data points of the things that affect the female libido, and men are okay with all those things. So if anything, it's about overfamiliarity, domesticity, and institutionalizing the relationship that women struggle with way more than men do.
Wow, that's fascinating.
So to be fair, some of that is a culture. There's a cultural context for that. I don't know that that's really about primatology. I think that might also have more to do with the cultural context that leads. I think that when we talk about sex research, it's very, very difficult to generalize about research because it's always done within a specific cultural context. So I think that some of the things that Wednesday just said are relevant because there's a cultural context for a female in that kind of a relationship. So if we're talking about a traditional heterosexual relationship,
That's right.
There's going to be a context to that relationship that changes when all of those things happen, that aren't necessarily going to exist in the same way, perhaps if it's a same-sex relationship or if it's a non-traditional relationship.
100%. And you know, when we talk about, well, go ahead, you wanted to ask us questions.
Well, what I was wondering is that when you said that you went to Dr. Creatura and she saved you in terms of you losing your libido.
Yes.
So there's the emotional part of it, and then there's the physical.
Right.
So, and obviously after menopause, so I didn't know, I just felt like, okay, if you feel that your vagina is lubricated, then everything's all good.
The reason for that is that men have done the standardization, right? The important thing is like, can you get a penis into a wet vagina? And then if you can, then you're all set, right? That's the whole thing.
So
it's really not about that for most women, right?
What happens to your vagina after menopause?
It's not just your vagina, it's all your genitals, right?
Okay.
So
Louise.
we focus when we focus on just the vagina, we're really disregarding everything that really counts. And the vagina is just a passage for a penis or a baby or menstrual blood or a location to store your tampons. It's not really important sexual. It's not. So
it's important to men because we fetishize intercourse, to your point.
Exactly. So the reason that I think Wednesday likes to start this with just explaining how important it was for her to understand that her clitoral anatomy was something that was never focused on in her sexual education is that I think in general women aren't really informed about their anatomy. I would imagine that, and this is not to diss anybody who's here, but I have a lot of patients, like people who are in this event, who come to me and say, something's bothering me down there, and they're not quite sure where or how to describe it or what words to use because we don't really educate people about their bodies properly. So back to what I was about to say, all of us will experience some decline in our sexual sensation and arousal that's implemented by the decline in hormones. So there are very specific endocrine events that happen to women, and they are responsible for a change in our sexual function. So if you're not educated about that, a lot of people just think that it's a normal process of aging that they have to live with and that there's no treatment. So there's quite a lot of treatment.
So the lining, so what exactly is happening, and then how does it affect you? Does it make painful, intercourse painful? Kind of increase in UTIs, which is, I've heard that's kind of a connection as well.
You've probably heard the term vaginal atrophy or vulvovaginal atrophy or even genital atrophy, which is used less frequently. And it's a term that actually most people don't really like, right? They don't like the idea that anything actually atrophies. It doesn't sound good. But we've actually decided in sexual medicine to start using this other term that just rolls off your tongue called genital-urinary syndrome of menopause. I don't really feel like it's an improvement, but it's more descriptive because it really addresses how all of the genitalia, including the urethra, the clitoris, the pelvic floor muscles, even perhaps the anus, there may be some receptors there. I don't think anyone's even looked at it yet. And I think certainly the bladder are all affected by the decline in hormones. So unfortunately, as we age, and this doesn't happen just at menopause, it actually happens when you're about 35 years old, you actually start to have a decline in all of your steroid hormones. So when we talk about menopause, which is the last menstrual period, the events that are leading up to menopause actually start 10 or 15 years earlier for most women. And that leads to some of the symptoms that you're describing, right? So if there's less hormone perfusion, there's less vascular perfusion, there's less lubrication, the genitals shrink, there's more pain because the genitals themselves are thinner, so the mucosa is less, the elastin is less, there's less collagen, just like everything, your face has less collagen than it had 25 years ago. Your genitals do too. So every part of your body is affected by aging.
And I wanted to say that one of the most interesting things that you and I have talked about are the studies that show that vaginal health is a use it or lose it proposition, right? And we've talked about how even if you do it by yourself, like if you have a nice little vibrator like this that looks like a necklace so that I can take my vibrator with me everywhere. And the women who work at TSA are always like, damn, what is that? And we have a conversation about it. Okay, so if you are masturbating regularly, or if you don't like intercourse, you don't have to have intercourse. Sex is many different things. It's not just intercourse. Sex is fooling around. Sex is grinding. Sex is anything that gives a woman an orgasm.
It's thinking about it.
It's thinking about it, whatever it is. So if you are masturbating or doing some of these things that bring you sexual pleasure, you're actually, as Chris is suggesting, you're actually bringing oxygen-rich, nutrient-rich blood to those tissues and almost like rejuvenating them. And I just want to interject something, which is that in some countries in Western Europe, doctors tell women, why don't you have an affair when women are starting to go through menopause? I'm not recommending it, but in some cultures, menopause is a time when you can't get pregnant anymore and it's time for sexual adventure, and even medical professionals, even if they won't straight up prescribe it, they encourage women to become more sexual during these years. And
she's the glass half full, I'm the glass half empty.
And that's
there are definitely places in the world where that's not safe for a woman. So
that's
as
right.
much as we want to be very pro
That's
pleasure,
right.
and we want to point out that we want to encourage women to explore pleasure, for most women, they can't even discuss the issue of pleasure because sex is actually connected to all other kinds of transactions and safety and risk of violence.
Yes.
So there's myriad reasons.
So
that
in
women
this
cannot
privileged
express
room,
themselves.
in this privileged room, and I always say that everybody thinks the United States is so enlightened, and I say, really? It's just like Saudi Arabia, where you could get thrown into a swimming pool and killed in an honor killing for having your hair showing or kissing a boy. In the United States, if you're a woman who decides to be sexually autonomous and that you don't want to be monogamous anymore, you could get shot in the face by your boyfriend, right? So in this very privileged room, some information that might be helpful is that there are places in the world where menopause is considered like a start to a new kind of sexuality. And a freedom.
Right.
And that was my experience, and I just needed my body to cooperate with my feeling that like, I can't get pregnant, thank God. I'm not getting my period, thank God, because that thing got like a slasher film at the end. I have the most intense, like, an amazing social network of my life because I've been working on it for years. My career is on fire because I'm mature now. I don't feel like a 35-year-old wondering who the hell I am. My kids are fledged. I was like, it's on. Then I went to her, and I said, I need need you to make my body understand
How I
that
feel.
I'm fucking on fire right now.
how do
And
you
she
do
did
that?
it, and she did it.
Okay, so how do you do it? Because, okay, so the perception is hormones are dangerous. They'll give you cancer.
So that's-
Or
that's-
natural hormones are not dangerous.
Right,
So,
well, those are
so
two
do
of the
tell.
most important myths that I would like to dispel, because first of all, hormones are not dangerous, but all hormones have side effects, and there's not any one regimen that I would recommend for all people, all women, we'll say all women here, or people that aspire to be women. So I think it's important to remember that part of Wednesday's reason for writing her book, which is beautiful, so I hope you enjoy reading it, is that so much of what we learn is completely wrong. So she said it so nicely, untrue, it sounds almost poetic. But in my field of medicine, a lot of what we believe is wrong, and a lot of what we actually convey to our patients is untrue. So the concept that hormones are dangerous is a value-based concept. They're dangerous for some people, there are some risks, but there are some big benefits. So overall, when we talk about using hormone therapy after menopause, there are many more health benefits than risks, but the risks get overblown.
Could you talk about what was the study that was in 2000 that got us all freaked out about HRT? Can you clarify that?
Sure. And we're going to get back to the other idea that some hormones are not dangerous, okay? So the WHI study was a study that was completed in 2002. So I have a colleague who likes to say that it started the flush that was heard around the world when everybody threw out their Premarin. But the study was a study that was really designed to answer the question of whether or not we could use hormone therapy as treatment or prevention of cardiovascular disease. And that was the reason it was started. So it was designed specifically to look at one particular regimen of hormone replacement and look at that regimen and see if it actually decreased the incidence of heart disease. So the study answered the question pretty quickly. And the reason that the answer was no was that it looked at women remote from menopause who were not having any symptoms. And this is a different class of women, a different type of patient than the patient that most of us treat and want to study. Which means that if you take women who are a decade past menopause who aren't having symptoms and you treat them with estrogen, you don't have all of the benefits. And I won't list all of them for you, but I will make a short list for you. There's a reason to use hormones because they can protect your brain, they can protect your genitals, they can protect your bones, they can protect your colon, they possibly protect your skin, they might actually save your hair, they might protect your mood, but most of what we know about hormone therapy doesn't come from the WHI study. That study specifically addressed whether or not hormone therapy that was oral and hydroxyprogesterone acetate and conjugated estrogens was the specific hormone that they studied, showed that it wasn't useful for preventing heart disease and remote from menopause. Didn't really show anything else. We already knew that estrogen was associated with a higher risk of breast cancer. And I think that that's true whether you make it at your local pharmacy, whether you buy it in a little bottle in your health food store, or whether you use an FDA-approved product. There is a slight increased risk of breast cancer the more years the breast sees estrogen. But if you look at overall all-cause mortality, it's decreased in women who take hormone therapy within the first 10 years after menopause, and it's about equivalent for women remote from menopause. And when I say about equivalent, it's because we don't actually have that much data on women remote from menopause on any other regimen other than the one that was used in the WHI study. So all hormones are not equal. It would be like saying all antibiotics are the same, right? It would be like we studied one antibiotic and said, now antibiotics don't treat pneumonia. Well, the antibiotics didn't treat that pneumonia. But we have lots of different hormone therapies, and they are usable in women with different types of symptoms, and they have a different safety profile.
And how about the idea of using a laser? Because if lasers are used if you're having issues with bladder control or with the lining getting thinner.
Right.
So what are your thoughts on that?
So there's a lot of energy-based treatments that are used in gynecology, even though they've never been approved for use in gynecology. So the laser treatments that you're referring to, a lot of people are advertising this type of treatment to basically injure the vagina in hopes of actually restoring the vagina or rejuvenating the vagina. So many of you may know that if you damage tissue, that you stimulate collagen formation. So you can get your face lasered and it's going to look like plump and irritated for a few weeks, and it's going to look a little better than it did before you had the injury. But then it's going to go back to normal most of the time. So people decided to apply the technology of the laser to the vagina with the idea that you would actually rejuvenate your vagina and it would be the way it was when you were 20 again. There are not really great studies that show that to be true. It's actually widely used by people that are not gynecologists and not sexual medicine specialists, so I don't use it. I think that there's a great economic motivator for these treatments, and there's a great deal of negative campaigning towards women to make them feel bad about their genitals and think that somehow if you stick a laser in your vagina every few months that you'll be young again. I'm a little bit skeptical.
And I'm going to say, as somebody who researched it for Untrue, and I interviewed dozens of experts, including Chris, I'm going to say that anybody who tells you to tighten or rejuvenate your vagina is not your friend.
Wow.
They don't care about vaginal health. They care about whether the vagina is good and tight for whom. For whom?
I don't really think it makes your vagina tighter. For
It doesn't, and
it makes your vagina irritated.
So there are lots of false claims about it, and I think that it is a very male-centric paradigm about enhancing male pleasure or helping women feel like they will be more desirable to men, and I think it's absolute bunk.
Thank you.
I mean, to be fair, there might be some applications for it. I think if there are women who are absolutely dead set against using hormone therapy, that there might be some women that would have some short-term benefits, but it's a very costly treatment, and I'm not convinced that it actually has any kind of long-term benefits.
And I think it's meaningful, even though we know that sometimes FDA is just ridiculous. I think it's meaningful that twice, and once very recently, they have said that this is not a procedure that they recommend, and that it comes at the risk of creating pain for women. So women are basically taking risks with their body, taking the very real risk of creating pain for themselves, sometimes long-term pain, on the promise somehow that they might create more pleasure for men.
It's also important. Well, there are all different kinds of energy-based therapies, but the laser, the Mona Lisa is one of the brands. It's also important to remember that devices get approved by the FDA if they can show safety. They don't have to show efficacy. Whereas drugs can't get approved unless they show efficacy. And when they show efficacy, then they have to show long-term safety. So the reason we don't have any drugs that are approved, that contain testosterone for women in this country, is not because we don't have efficacy data, it's because we don't have long-term safety data. And the standards are quite different for the approval for drugs for women.
There's nothing wrong with your vagina.
No, the vagina is just wonderful. Atrophied mom. In terms of sonogram, mammogram, just want to touch on that. Mammogram once a year still?
This is like beyond what we're going to talk about today, but I'm just going to say that there are definitely data to support less frequent intervals. And there's a big study that just came out about MRIs, and you probably don't want to talk about breast imaging. I'm not a breast imaging expert, but I will say as a women's health expert that if you do more imaging, you will do more biopsies. You will get more diagnoses, and you won't necessarily get less breast cancer mortality.
What would, can I just ask, what would be not a typical, a hormone therapy protocol that you might use for somebody who's experiencing, let's say, pain with intercourse or?
I would say rather than a protocol, I would really, she was asking if there was a certain hormone therapy protocol that I would use for somebody who's experiencing pain with intercourse. So if I have somebody who's having inserted sex of any kind that's painful, that usually requires a pretty elaborate evaluation. It's not always just about hormones.
Right.
I do use local estrogen and testosterone that's compounded for the vestibule because I think it's really effective. But there's no testosterone that's approved for use in women in the United States, so I use it off-label and I compound it. But I wouldn't say that there's a protocol for treating pain. I have my own protocol for a particular type of pain that I think is hormonally mediated. But most of the patients that I see for pelvic pain have complex issues, so that I wouldn't say there's one treatment that I use.
And one of the things that I like that Chris Creatura did before other doctors were doing it was we talked about DHEA, and there's a fabulous study. This is where reproductive and sexual health intersects with sexual pleasure. So DHEA is like a precursor. It helps you make both estrogen and testosterone. So if you're a woman in your 40s, this is relevant to you, and you don't have breast cancer in your family, this is relevant to you. There was a study done of DHEA. They were actually talking to women who were infertile and trying to help them with their infertility, help these women get pregnant. So they started giving them DHEA, and these women took the DHEA for a while, and the doctor said, okay, it's having no impact on your fertility, stop taking it. And these women said, what are you, high? I'm not going to stop taking this stuff. These women were reporting that they had greatly increased sexual desire and arousal and better orgasms. So the researchers said, okay, hold on a second, let's have a look at what's going on. And when they actually broke it down, there's something called the Female Sexual Functioning Index, the FSFI. And what they found is that the women who went into the study who had the lowest scores on the Female Sexual Functioning Index, who reported the lowest desire, lowest arousal, dumbest orgasm. Sorry, no orgasms are dumb, but you know what I'm saying. They saw incredible improvement on DHEA, including something like a 45% increase in sexual desire, something like a 50% increase in sexual arousal, and 55% of these women reported that they were having orgasms for the first time, or that they were having much improved, fun, great orgasms. So leave it to Chris Creatura. She was the person who said to me, how about some DHEA? Which wouldn't be right for everyone, but was pretty good.
Fernand Brie is actually the person who did all that research in Montreal, and he actually really published beautifully on how DHEA works inside the cell. DHEA is actually now available in the United States. There's an approved drug called Intra-Rosa. I don't know where they come up with these names, but it is DHEA suppository.
It sounds like the title of a painting by Georgia.
It does, sort of, right? But there's some other drugs that are now approved for women who have sexual desire disorders, and there's a new one that is actually called bremetalotide that it has a new name called Vyleesi. That you can inject when you want. So it's the first drug that's been approved for women to use as needed, that people keep referring to as the female Viagra. It acts in a completely different way. The mechanism of action is different, but it just became available a few months ago.
Karen?
So I want to go back to the drop in libido and all that, and I guess I'm in full disclosure here, but I separated from my husband, reconnected with a old flame, and all of a sudden, after 26 years, I had a new guy in my life and couldn't have an orgasm. And I went to my gynecologist repeatedly, a female gynecologist, until I finally pushed it. She didn't send me to someone who could help me, so I finally ended up going to someone, and I almost at women's. And it's like, I really think there's an education issue here. I think as a woman, it's like, oh well, I'm premenopause or menopausal, and of course, but I'm like, this does not make sense. Like all of a sudden, I've got this hot guy in my life for the first time in 25 years, and I can't, I can't come. So it's like, why don't more doctors, especially like the women?
Because there's all sorts of misinformation in the world. It shouldn't surprise you that even in OBGYN there's fake news, right? So, and there's also a lack of information because we haven't really emphasized women's pleasure. There's a lot of, even I was on PubMed this afternoon looking at some of the studies that we were talking about, and I realized that there's still a lot published about how testosterone really isn't important for women, even though women have 10 times the amount of testosterone that they have estrogen, right? And we know that testosterone is involved with sexual response, and we know that the clitoris responds to it. So why would anybody say that testosterone is a male hormone and that women don't need it? Unfortunately, we just don't have access to very much of it.
I want to just add to that something else, another piece, and this isn't about you. This is in women in general. One of the questions I get all the time from women is, I've never had an orgasm. How do I have an orgasm? And one of the things that I learned from sex researchers and anthropologists and everybody alike, they converged on a single point when I asked them about this, which is, and yours is a specific case, but in general, for women, know thyself. What we know is that women who masturbated when they were young, and it's never too late to start, or women who masturbate throughout their lives, develop the understanding of what their sexual repertoire is, and as we get older we can feel a lot more confident, hopefully, about communicating that to a partner. But in this case there was another issue, but often the issue is either that women don't know themselves and what they want because we've been actively discouraged from figuring out what we like. And why are we actively discouraged from figuring out what we like? Because in our culture, sex equals intercourse. Stop fetishizing intercourse and women will come, right? Only 18, can I get an amen? Amen. Our friend Debbie Herbenick is a sex researcher at the Kinsey Institute, and she recently did a study in which she discovered, it was a very well-designed study, she's an amazing researcher, only 18% of women who responded to her study said that they could have an orgasm from vaginal penetration alone. You are totally normal if you cannot come from a penis going in and out of you. Because who has that clitoris? Hold it up.
Where is the clitoris? Where
are they? Hold them up if you have them. Okay? Because let me just say the most basic thing about anatomy. For some of us, the vaginal opening is far from the clitoris and the penis is not doing it. There's a reason that lesbians don't have an orgasm gap. 80% of the time they're having sex, lesbians are having orgasms. Do you know why? They're not just putting a penis in and out. They're doing what women who have clitorides, that's the plural if you want to use that at a dinner party. They're doing what women like. What about among heterosexuals? There's a big old orgasm gap. One statistic is that men in a heterosexual encounter have orgasms 22% of the time more than women do. Another statistic from our friend Lori Mintz, whose book Becoming Clitorate is awesome. Another statistic is that in heterosexual intercourse, a man has 3 orgasms for every orgasm a woman has.
No.
So if you're a woman who is not having an orgasm, see if there's a medical issue, and if there's not, the issue is patriarchy. Right. The issue is that sex equals intercourse, and you can change that one sexual encounter at a time.
We have one more question.
I just wanted to ask Chris to talk about bioidentical.
Yes, because I was going to address that. Yes, thank you for reminding me. Yeah, well, when I was going to talk about things that were untrue, the idea that hormones are dangerous is untrue, but the idea that bioidentical hormones are safer is also untrue. So it's really important to remember that because of the way the FDA functions and because of the WHI, every single drug that contains any kind of estrogen receives the same kind of black box warning that dictates that this medicine that your doctor just prescribed for you is going to kill you, is basically what it says. It tells women that if they take this estrogen, that they're going to increase their risk of stroke, heart attack, blood clot, probably dementia, urinary incontinence, gallbladder disease, did I forget anything? Breast cancer, endometrial cancer, none of which is actually biologically accurate. So a lot of patients will say, well, I'm not going to take that stuff. I want to take the bioidentical hormones because I went to see a special doctor who's a hormone expert who told me that they could fix a special recipe for me based on my spit. And I'm going to spit into this lab, I'm going to spit into this beaker, and they're going to figure out what the right recipe is for me. And that's complete nonsense. There's no scientific basis for that. One of my friends says that it would be nice if 1 milliliter of spit could actually resolve all the mysteries of menopause, but it really isn't. There's no scientific basis for it. So if you're taking bioidentical hormones, it's really about marketing. And I prescribe bioidentical hormones all the time. They're basically the same molecule that your ovaries used to make. So it's the same hormone, but they're all synthetic. And there's no reason to believe that if somebody's synthesizing a hormone for you that they made up at their local pharmacy based on your spit, that that's going to be any safer, or, it could be more dangerous than what we use in the WHI or what I might prescribe for you that is FDA approved.
So, I've been on bioidentical hormones since menopause, forever. And they work well for me. Why would you prescribe that as opposed to regular hormones?
Well, the term bioidentical is something that I object to because I think that people use it in a kind of cavalier way. Like I said, I only prescribe bioidentical hormones, so the hormones that I use are not the same as the hormones that were used in the WHI, but it doesn't mean that they're necessarily safer. We have some data that we know that there are certain reasons why you want to take your estrogen through a patch or a gel rather than the oral conjugated estrogen. It's better for your lipids, it's better for your brain, it's better for your heart, it's better for your sexual function. But all estrogen increases your risk of breast cancer, and all estrogen protects you from hip fractures.
Even if you don't have history of breast cancer.
Most people who have breast cancer don't have a history of breast cancer in their family, and most people who have breast cancer never took any hormones. So remember that just by virtue of being a woman, you have a high risk of breast cancer.
And also, one of the things that Chris taught me was, and other people taught me too, if you care about bioidentical hormones, there are FDA approved bioidentical hormones, and that doctors have been working with for many years. So, you know,
You don't have to have something mixed up for you that's special based on your saliva. But to be fair, because there is no testosterone that's FDA approved, I do prescribe testosterone that is actually made by compounding pharmacies because there's no other alternative short of getting it from Australia.
And you have to trust that your doctor gets you a good compounding pharmacy because there can be issues with compounding. So I think that if you want to go that route, and some of us have to, like for me, the lowest level of estrogen was too high, and so we had to do something special. A really good doctor is your best guarantee that your compounding facility is safe for you. And I just want to bring us back to another point, which is that your reproductive health in your menopausal years is not just about health. The World Health Organization's definition of sexual health includes the words sexual pleasure. So when you're getting your menopause hormones on, it's not just to get your brain in order and your heart in order. It's because having sexual pleasure is part of sexual health. They go together. You can't have sexual health without sexual pleasure. So that's part of the service that these doctors are doing for you too. You deserve sexual pleasure into your menopausal years. And
I don't think you need a doctor to have sexual pleasure. It might just help if you're having trouble finding it. But
it can help you feel entitled to
I prescribe a lot of bibliotherapy too, a lot of books that actually help patients figure out what their sexual scripts are, teach them how to masturbate well, teach them how to fantasize, teach them how to expand their sexual script or even figure out what it is in the first place.
Think about other forms of relationships, everything.
You have a question, Beth?
Yeah, I mean, you guys are like totally blowing my mind. I can't decide if I'm like excited or angry about all the stuff that you've grown up with. And just like very, very quickly, so I was married for 10 years, moved to New York City and just like dated my ass off. And I remember the first kiss that I had as a single person like totally blew my mind. And it was like, I felt, you know, everyone's like, oh, you know, it's normal to like not want to sleep with your husband, like actually sex isn't, you know, like sexual attraction to your partner isn't that important because it'll wear off, and that's like totally normal. And so I was single, I was dating, I had like all of these experiences, and just like what you're saying, it's so important, you know, for women to feel like they have the right to enjoy sex. And even like the way that sex is presented, it like ends, like if you watch porn, it ends when the guy comes.
Yes.
Like that defines the arc of the story.
Yes. That's the narrative that we tell about sexual desire in our culture, right? We tell the story that sex begins with a man's erection and ends with a man's ejaculation. Where am I in there? I don't know.
And I've been in situations where it's like, well, it doesn't end with my orgasm because he hasn't. So it has to keep going even though we lost interest. That's what expected of us as women is that we don't know that it can end at any time. It can end whenever we want it to.
I think
So
one of the
I really like,
I think one of the reasons you're angry and excited is that there's a lot of sexual scripting that goes on within any culture that is rather constricting, right? So I think one of the reasons that most of you are here is not because you think that I have the answer for your hormones or that Wednesday's figured out exactly which primate study is going to solve your questions about sex. It's because you're interested in learning about something that affects all of us and about which there's a lot of misinformation.
Yeah, totally. Just one question for you. So I have a history of breast cancer, and sometimes when I hear these talks, it's like, oh, there's all this, there's all these hormone things, and I always feel like, oh, I can't do any of that. So, I mean, I guess there's all the types of cancer, but what does the research say about people that have?
Well, the research is really poor, unfortunately, and I take care of a lot of breast cancer survivors in my practice, and many of their oncologists and I work together to try to find a solution for patients so that they can live their lives. Because one of the problems with such regular mammography is that we have a lot of young women who get diagnosed with really early breast cancer at a very young age, with a very, very high chance of survival, but a very long life to survive with breast cancer. So we then treat these patients with drugs that really destroy their sex life, right? We put them on aromatase inhibitors and SERMs, which are selective estrogen receptor modulators, drugs that really knock out all your receptivity to hormones, which means for a lot of women they live a very long time without actually having a good sex life. So they need ways to be rehabilitated. So there are a lot of ways that we can use local hormones and a lot of topical things that I use for vasodilation that actually change some of the blood flow to the genitals that can improve their quality of sensation and their arousal without putting them at increased risk for a recurrence. And there's not good research on this, right? Because nobody wants to research this. No one's going to give a whole bunch of breast cancer survivors drugs and randomize them and see who dies first. No one wants to do that. So it's really a process of shared decision making and using your head, right? Like what's practical for the patient.
I have a question and a comment. So if monogamy is kind of biologically counterindicated, and for the most part, but I mean,
I like the way you said that.
or maybe not in, if you maybe go a standard deviation away from the mean, most women are not probably programmed biologically to have sexual desire after a certain period of time in a monogamous relationship, and yet the cultural scripting and the kind of monogamy myth is like all pushed to one side of the curve. Then how do you, and given that attachment injuries are real,
Yes.
right? Like how do you, I mean, I ended up reconciling it with a divorce, but I didn't, and it's cool because I have a super hot girlfriend now. Thank you very much. But I think that there's got to be a better way, and I don't think everyone's just going to come out as poly all of a sudden after thousands of years of patriarchy and whatnot, and ownership of women.
Okay, so does everybody understand the question? The question is, we have all these great longitudinal studies that show that monogamy is harder for women than it is for men. We know from a scientific viewpoint that we habituate to a stimulus over time. We know that it is scientifically virtually almost impossible that somebody would really be zealously enjoying monogamy for year after year after year after year after year, given what we know about habituation and desensitization to stimulus over time. Okay, and now your question is, now what, right? What should we do with this information?
Even if you can deprogram your brain and go, I understand that monogamy isn't necessarily the greatest thing in the world.
Yes.
We are deeply encoded socially.
Yes, okay. So yes, it's very dangerous in many contexts for women not to be monogamous, including in the United States. The worst thing that can happen is you can get murdered for it. The best thing, if you want to call it that, is that you can get slut shamed at the club. People can look at you funny. I know women who have had affairs on the Upper East Side, and their lives have been destroyed and their health has been destroyed because they've been so judged and ostracized for it. So the stakes are very high. The other thing, we evolved as very flexible social and sexual strategists. We can flourish in a lot of different ecologies. We can flourish in monogamy. There are places in the world where there's polyandry, where women have many spouses. There are places in the world where there's polygyny, where men have many spouses. And we see that women can do well in all of these many contexts. In this particular ecology, what do women do well with? We know that women need variety and novelty and adventure in ways that have not been acknowledged by our culture. And we know that many women who seek it out report that taking those risks have been worth it to them. I interviewed many women, many of them were having affairs, they weren't disclosing their non-monogamous behaviors, and they were having a great time because they were thrilled that they were doing something naughty. I interviewed polyamorous women who were thriving and who really surprised me, and the data showed that they have great communication styles and often have really close relationships with their partners. I interviewed women in open marriages who every single therapist told me, oh, that can never work. But I interviewed women and reviewed data that showed that people in open marriages reported that they had great sexual and relationship satisfaction with each other and that they felt closer than ever. So the answer is going to be different for every woman. Some women are going to say, I'm bored with monogamy, this is killing me, let's go to a sex club. Some women are going to say, are you kidding me? My sex life with my husband or my wife is not exactly what I want it to be right now, but let's explore other options. My point is, let's get the fact out there. Struggling with monogamy is completely normal for women, not just for men. And now let's get another fact out there. When you crunch the data and when you look at it, in the industrialized West, anywhere between 20 and 45 to 50% of people, male and female, are having affairs. Non-monogamy is a normal part of the sexual repertoire of a healthy human female. If you are bored with monogamy, you are a normal, healthy human female. If you are thriving with monogamy, you are a normal human female. But I want you to feel entitled to have the conversation. Raise your hand if you got married and nobody talked about whether you would be monogamous or not in your marriage. Raise your hand if you never had a conversation with your spouse before you got married. So you're telling me, the rest of you, had a conversation with your now husband. Honey, are we going to be monogamous? If you did, God bless you. If you didn't, you should feel entitled to have that conversation now. It doesn't mean that you're going to act on it. It doesn't mean you're going to step out. It doesn't mean you don't love your spouse. But you're entitled to have a conversation about monogamy if you want to have it. And you can blame it on me. Oh my God, I heard this crazy woman talking tonight. Because then it won't feel so threatening.
And my comment was about you had said about straight, like that. I think it's because most of the studies are done on heterosexual women.
We have to talk about it.
You were, I'm all for blaming men and the patriarchy, but I do think the fact that there are studies that show that actually two women couples have the worst kind of rate of lesbian death is a term for a reason.
Women get bored fast.
Right.
And then you have to do all kinds of
two
stuff.
women and no erection.
And just putting it out there that it is normal that the woman gets bored. It's not that it's a bad relationship. It's not that it's a bad. Yes.
That's what I'm saying. That the studies seem to show that gay men have the most coupled sex.
So the point being that don't feel like if you're bored with monogamy and you're in a long-term relationship and you're bored, it's not that the relationship is bad. It's not that your partner is bad, and it's not that you're bad.
How much time do you have? Because I don't know. Okay, Robin.
Should women who have gone through menopause automatically have their doctors talk to them about supplementation?
Somewhat. I didn't know what you said.
Should women who have gone through menopause automatically have their doctor speaking to them about taking different hormones?
No, that's a good question. I mean, I feel like
What was the question?
she asked if a woman is going through menopause, should she be talking to her doctor about whether she should be taking hormones? I mean, I have that conversation with everybody. I'm constantly asking people about it. Some of my patients don't want to talk about it. But I'm always asking when I see somebody who's anywhere between 40 and 60, are you having hot flashes? How's your sleep? How's your sex life? What's going on with you? Yeah, that's what I do all day. So for me, yes, it seems like there's no way to avoid that conversation. But again, there are people that I see who look at me like, I don't know why you're asking, I'm fine. You know, my periods are stopped, I'm fine. I just talk about their sexual health in a way that most people don't. That's because that's what I do. But I think that for each individual in this room, there's going to be a completely different answer to that question. I just think that when we're looking at all of us aging and lasting a lot longer after menopause happens, now that we don't die in childbirth anymore, that we have to really think about what we know about living beyond menopause and try to be more proactive about things that we might consider doing. Because there's a lot we don't know about why women have Alzheimer's at such high rates. I happen to think that it has a lot to do with testosterone, but that's not a universally felt belief, and I don't have the science to support it. There's a lot known about how women die of fractures and fracture complications that we've known for a very long time, that we can treat with hormones and lots of other interventions. There's a lot that we don't know about cardiovascular disease and how to prevent it with hormones. So I think that it would be not proper practice for me not to discuss that with anybody who's going through menopause.
Okay, do you have a question on or, okay, go ahead. I don't.
Can I ask a follow-up question to that? So I went into early menopause because I had early endometrial cancer and had a full hysterectomy in my early 40s. And my gynecological oncologist and I had a conversation about, should I start hormones, do I get estrogens and that. And I have this I am Wonder Woman, I don't need it, I exercise, I'm still sexual, my vagina's still wet, it's gonna be wet even if it's not wet,
That's all good. I mean, your brain is going to control all this
I'm
stuff.
listening to all this time and gosh, was I just so hyper-focused on it would be better if I don't take anything, any medications, any drugs, any hormones, and I feel well, maybe I thought I was enlightened, and now I'm starting to think, oh wow, maybe I was just really myopic in my thinking there.
I think that we're myopic in our thinking as physicians too, because like I said, I take care of a lot of survivors, and I think that when the patients go to their oncologist and they ask about their sex life, they often get a look like, I saved your life, you're not dying of breast cancer, you don't have endometrial cancer anymore, why are you asking me these questions? But the reality is we're really not serving you well if we don't address how you're going to survive and how you're going to live beyond the cancer, which I hope is going to be a really long time. So I don't think you're alone in that experience at all. I think we failed you. I think that our field doesn't really do what we should be doing for cancer survivors.
So I just want to extend a little bit about what you're saying in terms of acknowledging the normalcy of the monogamy issue by also saying that if you choose to stay in a relationship that is monogamous because the other partner does not want to open up to it, that there are sex therapists that can also sit down and talk about how to make the relationship filled with play and fantasy and exploration, and to improve on intimacy. Should you choose to stay and want to explore that in the relationship, or should you want to negotiate with a partner who's unwilling, what it would also look like to expand beyond that and open it up?
I think you'd have to talk to Dr. Elizabeth Grill, who's a wonderful sex therapist who asked that question.
Sex therapy plug in the room.
Yes, 100% that people need to know that they have options if the monogamy isn't working. I get into a lot of the options in my book on True, a lot of the database things that people can do, including weird things that sex therapists will tell you, like there's this thing called misattribution of arousal. If you're not feeling excited by your partner anymore, try jumping out of a plane, skydiving with them, and that, you don't have to do anything that extreme. You can take ballroom dancing class, and the excitement that you feel and the adrenaline rush that you feel, your body will misrecognize that as arousal, and you will feel passionate again with your partner. There are a million hacks, there are a million tricks, they're all in my book, but there is no substitute for sitting down with a sex therapist if you're bored or struggling with monogamy and figuring out options, because you have many, many options.
We have actually a few sex therapists in the room. We want to raise your hand? There's like a bunch. So there you go, girl. Yeah.
I just have a basic question. If you don't, if you're not interested in, moving out of your very happy monogamous relationship, but you are, you need, the way you spoke about Wednesdays is a repertoire week, but then it comes to Chris, like you spoke about being, if your libido was waning, shall we say. So is it basically just all drug-based in terms
Is it all?
drug-based?
No, not at all. I mean, to this point about women needing novelty and variety and adventure, and you're saying if your libido is going down, can drugs help? Can hormones help? Yes. But if women have a demonstrated appetite, which I get into in my book, for variety and novelty and adventure, that might seem like a downside in monogamy, right? But it can be an upside because you can fake it, right? So many women told me of great strategies to remain monogamous but get the thrill that they would get from having an affair or from having a new partner. There's the oldie but goodie that when you go out on a date with your person, don't get ready in the bathroom side by side where he might leave his dental floss. Just get ready separately. Don't even see each other after work. When you show up at different times. Maybe wait, see your person go into the restaurant, see him or her across the room the way other people are seeing them. Maybe somebody will even flirt with him or her. And we know that when that happens, it creates the distance that women need to get that excitement back. That's just one thing you can do. People talk about lingerie, and to me, when people say like, oh, lingerie, that would be so fun, all I think about is like, oh my God, I have to get my legs waxed. But people aren't getting why lingerie works. The reason it works is because it hooks into not a man's desire for variety and novelty to have a new woman, but a woman's desire for variety and novelty to be a new person and to be with a different person. So if you look at lingerie, for example, through that lens, it's great. I'm sorry to keep looking at you. I'm looking at all of you. Fantasy is a really great thing. Justin LaMiller wrote a great book called Tell Me What You Want. He's a sex researcher, and he found what the 7 most common sexual fantasies in the United States are, and I won't bother you with them because you've already had all of them. But my God, use those fantasies, talk about them with your partner. That can make things so much less boring. It's unbelievable. And finally, I am a big fan. I am a feminist who loves porn. I need a t-shirt, feminist who loves porn. If you are a woman who is kind of struggling with your libido in a long-term relationship, porn can be a great solution. If you don't like what's on Pornhub, where the guy just is immediately like, doing things like, ejaculating on the woman's face or whatever, or the jackhammering a woman, these are things that women don't tend to have orgasms from. Check out the pornography by my friend Erica Lust, who's a feminist pornographer. Check out the work of my other friend Cindy Gallup, who's another feminist who makes porn. Find some pornography that suits you, that excites you, that you like to watch by yourself, or that you can watch with your partner. These are all different suggestions, and I have a million more, not a million, but I have a lot of other suggestions.
Will you put those suggestions on the Facebook page though, what you just said if they're not in your book?
Yes, they are in the book.
And you get a free copy of my book, so, well, you paid for it, you paid for it. Yeah, it's in there, it's all in there, you'll get your money's worth.
Yeah.
So I'm wondering, what is your book appropriate for a teenage girl? Because I think someone mentioned a 13-year-old daughter. A bunch of us have daughters, who are coming into their sexuality. I would like her to know things that I wasn't aware of. Some of it was tonight. So, what's, if it isn't, do you have recommendations for?
Oh, okay. Did everybody hear this question?
Yes.
This is,
She wants recommendations for books for teenagers?
And for teenage girls in particular. Okay, Chris and I are so big on this. The thing that is missing is sex ed, period, right? But the thing that is really missing is telling girls about sex in a way that isn't about terrifying them or telling them that their hymen is their self-worth, or only telling them how to protect themselves from disease and pregnancy, which is very important. But hello, the most important thing that goes along with all those things is telling girls that sex feels great and that you're entitled to these great feelings and your clitoris is awesome and orgasms feel really good and you deserve to have them. Okay, a woman asked me on Instagram, what the hell am I going to tell my 13-year-old daughter? Was it you? I'm kidding. So I went on Twitter and I asked all the sex researchers and sex positive activists that I know to please tell me what are the best sex ed books for teen girls. So go on my Twitter feed, it's Wednesday Martin, Ph.D. And they're the top of my Twitter feed. Jane, will you put that back on the top?
It's actually just Wednesday Martin.
Oh, it's at Wednesday Martin. But will you pin that tweet? Go to my pinned tweet, and you will see what women who are sex workers, women who are pediatricians, women and men who are sex researchers, the books that they got for their teenage girls that they love. And I'm going to tell you that one great resource online is Scarletine.
Is what?
Scarletine, like Scarlet Teen, but there's only one T, Scarletine. And another great one is Sex Positive Families, and they're on Twitter and Instagram. But go to that on my Twitter feed. And my book is more appropriate for like girls 17 and up. I've heard from girls 17 and up that they love it. It's just that the humor is kind of like New Yorker-ish and above. It's not that it's inappropriate.
What do you say for I have a 15-year-old son too, and I'd like him to be.
Yeah, so a lot of people on Twitter don't read. So when I asked that question, they told me books for boys and girls. So you'll find plenty of resources for boys as well.
So how do you address this? I mean, I don't know if it's really an epidemic, but for young women who are no longer teenagers, but who are young adults in their 20s, who are sexually active and who talk about never have, that they find it very hard to have an orgasm, who are not, sexually experienced, and they've had a lot of sex, but they have not been able to
show them the model.
What?
Show them the model. But I show them their vulva.
It's all about your
I get
clit.
a mirror. I show them their vulva. I teach them masturbation exercises. I give them books so that they can.
What is this
I don't think it's
about?
epidemic, but I have a lot of young women who are smart enough to ask me when I ask them how their sex life is. A lot of them ask me why they're not having orgasms.
And what do you say?
We talk about it. I ask them if they masturbate. We find out what kind of masturbation habits they have, whether if they can masturbate themselves to orgasm. Then I try to find out why they can't speak with their partner to incorporate what they do when they masturbate with their partner, so that they can teach their partner how to help them.
Yeah, and I think that more young women need to get the messages from their mothers very early on, and from other women in their lives, and we can be allies to women in their 20s and help them understand that male pleasure, that female pleasure matters as much as male pleasure. Women will be having orgasms at the same rate men are when women get paid the same amount that men do, and we have as many female leaders as we have male leaders, because they're all linked together. In the meantime, all of us in this room can be activists and allies to younger women and explain to them there's so much more to sex than intercourse, right? And you're not there to get men off if you're heterosexual. And, heterosexual sex is not just intercourse. It's really important that we change the definition of sex in every conversation that we have. A guy going down on you or a woman going down on you, that's sex, right? Grinding, if you like it, that's sex. And I think that when we start changing the language about what sex is, then we'll be getting to the kind of sex that women get off from. That's my answer.
I think that's a good place to end. Thank you.